Okay. Thank you. I'm joining from my phone, so you'll have to project the slides for me. Thank you so much.
It is on.
So, right, thank you. Next slide. So I'd like to thank the organizers, Dr. Hemant, for this wonderful opportunity. And this is actually a very excellent and comprehensive document, the ELN Guidelines 2020, and it has been written by a very esteemed body of experts. Next slide. So what's new in diagnosis and monitoring? Next. Not too much, but they've identified all the main things that we need to do when we have a new patient, and they've stated that quantitative PCR upfront is not mandatory, but we need to look at all the comorbidities to identify which of the TKIs is best for them. Next. The atypical PCR-able transcripts have been identified as a major impediment to identifying the response to patients. So it's important to make sure that your patient is not one of the 2 to 4% who has an atypical PCR-able at the baseline. Next. The definitions have been clarified of MR4, 4.5, 3 and 4 and 4.5, and they've said to avoid the term complete molecular response and instead go to molecularly undetectable leukemia. Next. The testing, which is going to be discussed further by the next speaker, has also been clarified, and the transcript numbers that we need for controls has been identified. So it's important to discuss this with your lab colleagues. Next. And it's clarified the way that we are supposed to monitor responses. And it said even in patients after MMR, we should continue the 3-monthly monitoring. And it's classified where cytogenetics is important and where it may be avoided. Next. So this is the main table that all of us use. And this has actually not changed too much from previously, except for a few of the things which I will be discussing ahead. Next. So the risk assessment, there are several new things. Next. And the ELL panel recommends the ELTS score, which is the UTOS long-term survival score. So this is an additional score alongside the 3 scores that we usually use. And this is important because it predicts the leukemia-related death in patients on TKI, because these patients don't die from leukemia very often. Next. And this assessment, as you can see, it has mainly the same categories as in the SOCAL, but with different weights. Next. And the importance is in this is that it's based on TKI treated patients, and the effect of age is negative in this because that's not very important in TKI related patients. Next. And this is just an example from the paper, and it has a link to a online scorer. Next. And it mentions in passing the implications of biopsy, which is important in 25% of our patients to define their disease and document myelofibrosis. Next. The most important thing it talks about are the additional chromosome abnormalities, which, if found at any time, make these patients high risk because they predict a poorer response to TKI and a higher risk of progression. Next. And this is where it is in the table. So at any time when they have this, this is considered to be a failure. Next. So what's new in management? Next. So when you're initiating therapy, we now have many drugs available. One of them is not available in India, but all of these agents, it says, are effective and approved in Firstline. Next. And it says when you're deciding on Firstline, look at the comorbidities, and the non-hematological adverse events should be separated into side effects, which affect tolerability and quality of life, and complications, which occur in less number of patients, but are very important because apart from the effect on health and quality of life, they may even cause death. So it's very important to look at these. Next. They also for the first time mention generics, and they say that they are an effective option for initial therapy. So generic imatinib has been given their stamp of approval. And it says to look at the lifelong costs when you are deciding about going for a drug that will give you a sustained deep molecular response, because then you can offer TFR to these patients. Next. And another interesting thing is that it talks about the 3 month and 6 month, which was there earlier in ELN. But I think to just notice that now the NCCN guidelines will also be harmonizing with this. So actually, you're not going to be changing at 3 months. It will be changing at 3 months plus. So so most changes will occur actually at 6 months, which is there in ELN. And now NCCN has also been adopting them because that's going to be harmonized. Next. So it talks a little about failure of first line. Next. Next, please. And the second line treatment, as you know, is very important. You have to look at mutations. And one thing that I thought was interesting was that even in the absence of alternatives, it says that TKI should be considered in chronic patients who don't achieve the cytogenetic response, because they can still have some survival advantage. So again, this was something that we were doing and practicing, but now what the practice that we had when we didn't have alternatives is now also being covered in this. Next. The TKI, and of course, we have to look at mutations. So this table is very important, though it does say that for bosutinib, we don't have too much data. So some of the mutation evidence for bosutinib may change. Next. So treatment beyond second line it says that we can't really come up with third and fourth and fifth line treatment that can't be formalized. But of course, we know that, so that's pretty much there. Next. And this is a very important table where they talk about end-phase CML and the different strategies of what to do. And one of the important things I saw here was that if you have resistance to a second-line TKI, whether first line or second line, they recommend going to ponatinib, which of course may be something that we would have to see in our scenario, or it says to go on to allogenic transplant. So this is an additional table which tells you what to do with more advanced stage CML. Next. And it really talks a lot about treatment-free remission. Next. And treatment-free remission is included in the table. So it says that the indication definitely would be if patients are in MR4 at least. And it talks about how to monitor them and when they have failure. So all of these additions are being included into our table 4. Next. And it summarizes some of the data from the studies. Next. And it emphasizes the criteria for patients who you are planning to put into TFR. So definitely these should be first-line chronic phase patients. And then it talks about the different other criteria that you should look at when you are deciding on whether the patient is motivated and suitable for TFR. Next. And it highlights the duration of TKI therapy, which it says should be at least 5 years for imatinib and at least 4 years for second generation TKI. And the duration of deep molecular remission should be at least 2 years. So all of these are very nicely laid out. Next. And it defines operational cure, which we had read about in some different papers. And this is different from resistance. And it is the persistence of detectable disease, either when patients are off therapy or in deep molecular remission. And this is most likely due to immune mechanisms or BCR-ABL transcript. Next. And to summarize, this is a really comprehensive table. It gives a lot of information on different scenarios and guidance beyond first-line therapy, and a lot of information on TFR. So a very good document and very useful for all of us. Thank you.
Thank you. Thank you very